My name is Joshua Spencer, and I'm a sophomore here at the University of Kentucky, currently on the pre-pharmacy track. I want to study pharmacy because, simply put, I want to help people. And I have found that most people who also want to practice pharmacy feel similarly. But what happens when helping a patient doesn't actually mean curing an illness or making them feel better? What happens when helping them means hastening their death? That is what I would like to address in this video. Clinical-assisted suicide. Some learning objectives to take away from this video are: 1. Understand what exactly clinical-assisted suicide is. Some questions to consider are: what types of medications are used? What is the difference between assisted suicide and euthanasia? Another objective to consider is discuss some of the legal considerations of clinical-assisted suicide, and similarly, discuss some of the social considerations of clinical-assisted suicide. First, let's look at the definition of assisted suicide. According to the American Nurses Association, in assisted suicide, the means to end a patient's life is provided to the patient with knowledge of the patient's intention. This differs from euthanasia because in assisted suicide, the patient themselves are given the means to end their own life, rather than the clinician carrying it out themselves. In Oregon, one of the few states in which clinician-assisted suicide is legal, the most commonly used drug for assisted suicide is secobarbital, followed by pentobarbital, both of which are medicines that normally help with insomnia. Now, let's consider some of the pros and cons of clinician-assisted suicide. One of the arguments for assisted suicide is that it relieves patient suffering. This would relieve physical symptoms like pain and nausea, as well as psychological problems like depression and anxiety. Another argument is that it would relieve the burden on family and friends. Some patients do not want their families to experience both the financial and emotional burdens of seeing the patient's health deteriorate, and would rather have the option than to see their family suffer. A third argument is that providing the option respects patient autonomy. The patient's life is their own, and since assisted suicide does not physically harm anyone else, the government should not prohibit the practice. I personally am against clinician-assisted suicide, and the following are some arguments against assisted suicide. One argument against assisted suicide is that it goes against the ethics of medical care. As outlined by the World Medical Association's International Code of Medical Ethics, a physician shall always bear in mind the obligation to respect human life. Medical professionals are charged with the duty to carry out medical procedures to aid those who are ill or disabled. This means always striving to find a cure and never giving up on a patient. Providing this option may weaken the reliability of healthcare professionals and hurt the doctor-patient relationship. Even still, medical interventions are ever-changing, so there is no telling when some new treatment may become available that might save the patient's life. Another argument against assisted suicide is that legal concerns can arise. The field is somewhat gray when it comes to determining who would be eligible for assisted suicide. According to Mary Lee Golden, a policy analyst, the actual number of those who would actually be eligible for assisted suicide is low, and of those, it would be likely mostly wealthy white individuals with good health insurance. This is a form of discrimination. Discrimination might also become an issue, especially for those who are too sick or disabled to perform the life-ending event themselves, which would compromise the idea behind assisted suicide and may lead to euthanasia, which is generally an even more unaccepted practice. A third argument against assisted suicide is that patient suicide requests could come from undiagnosed depression. A patient should not feel obligated to end their life because of fear of being a burden to anybody. Joshua M. Hauser, MD, believes that this type of response should prompt a clinician to search for interventions of symptom control and of psychological, social, and spiritual suffering, not hastening their death. This type of thought in depression is something that can be diagnosed and cured, and it should be considered that depression can play a huge role in a patient's decision to request for assisted suicide. Considering the pros and cons of clinician-assisted suicide, along with the fact that the American Nurses Association and the American College of Physicians and American Society of Internal Medicine do not support the practice of assisted suicide, it is clear that this type of action should not be carried out by any clinician. A healthcare professional should always hold a patient's health and life at the utmost importance. Providing this option of assisted suicide could compromise that duty. The legal and social considerations presented point to the overall unacceptance of clinician-assisted suicide. There are many interesting articles, illustrations, and facts and opinions about this topic, so make sure to check them out. I hope you enjoyed this video and thank you for watching.